Hello everyone. Thank you for showing up to this webinar. I'll briefly introduce myself and we'll wait for a few minutes and then we'll start. So my name is Dr. Taha. I'm an ECFMG certified international medical graduate. I'm working as a mentor and moderator at Med Exams Expert. Uh, we are doing this webinar to create awareness about our crash course, what we guys do, what we guys offer, and how we can help you USMLE aspirants. So if you have any questions, you can write that down before we start. This is Simpson is saying, how long would you say a person needs to study before doing the exam for step one? It it's uh, it's very difficult to answer this question because each individual is different. But uh, in general, it takes about 6 to 9 months to appear in step one, depending upon your basics and your base knowledge. But usually 6 to 9 months are more than enough to ace this exam. So we're gonna start. The way we're gonna do this is first we'll briefly give you some details about our crash course, and in the second half we'll discuss a high yield topic called Cushing disease. Uh, that's just to give you some insight about how we prepare uh, our resources and how we are going to take this crash course forward. So let's jump into it. So I gave you guys my introduction. I'll introduce myself again. So my name is Dr. Taha, and I'm an ECFMG certified international medical graduate. I'm working as a mentor and moderator at Med Exams Expert. We have other mentors as well, but I'm one of them. You will meet other mentors as well. So let's move forward. Okay, move forward, please. So uh, this slide is just to show our key features. So our crash course is divided into 25 live lessons, more than 25 live lessons actually. Each lesson will last about 2 to 3 hours, depending upon the topic or depending upon the system we are doing. Uh, we will complete these 25 or more than 25 live sessions in 2.5, more than 2 months. Uh, uh, and we will try to cover as much as we can. And We'll cover almost everything that you guys need to know. So this course comprises of 25 live sessions, more than 25 live sessions actually, led by mentors who are highly skilled and have a lot of experience in teaching the USMLE. Uh, and we are also providing all the important USMLE question banks that include AMBOSS, that include UWorld. And the good thing is that uh, the crash course will last about 2.5 months, but the access to question banks will is extendable. You can have access to our question bank for like 6 months if you want. Just give me a minute. Am I audible? Can you guys hear me?
Yes, Dr. Taha, you're audible.
Okay, fine. So uh, we, like we said, there are 20 more than 25 live sessions. We are providing important all the important USMLE question banks that include AMBOSS, that includes UWorld. Uh, the and the access to that will is extendable. You can have access to our question bank for like 6 months if you want. So that's a big plus. Then we will provide all the essential books. It includes first aid, boards and beyond, master the boards, board and beyonds, and we will also be providing mock tests like NBME. So it's basically a complete package. Not only you are getting live lessons, you're also getting access to every important source out there. You are getting free question banks. You are get not just one. You're getting two question banks. You are getting all the books that you need. You are getting uh, you're getting NBMEs, and you are also getting all the other self-assessment that are out there. Move forward, please. So in addition to our question banks, our live sessions, and our books, we are also providing flashcards. We have access to uh, Anki deck, the important Anki decks. We have downloaded them all, and we have created our individualized notes for people like you that are very new to this and they require like a little more detail because in our last webinar we talked about that first aid is a book. It's a review book and you need to add a lot more in it in order to understand that. So that's why we are also making comprehensive and very organized notes for you people who are very new to this. We will also be creating a lot of quizzes just to track your progress and test your knowledge as we go along this. And we, what we have done is that uh, since we created our own question bank. So if you don't know, uh, there's a group on WhatsApp. We'll share the link below. In that group, we create questions on daily basis, and it's been, I think it's that group is going on for like 2.5 months now. So we have like around 600-700 questions that are very unique and that are very similar to what you guys are going to see in your exam. So uh, just to summarize, this is just not a one-to-one live session that we will be concluding. We are gonna provide complete package that will include question banks, that will include books, that will include uh, flashcard, that will include self-assessment, and you're not just getting the NBME self-assessment. You will get all the self-assessments out there. Uh, and we will also be providing quizzes, notes, important exam-like questions. like we discussed. So it's very comprehensive, and it's very extensive. No problem. So before we start our main topic of the day, if you have any question, you can ask.
Assalamu alaikum. Am I audible? Am I audible?
Yes, you are audible.
Yeah, thank you so much, Dr. Taha, for providing these free lessons. It's your second time. I saw the recording of the first one. That was very nice. My concern that you said if I can take a crash course, so the availability of a Q bank is for 6 months. So it's with the payment or without payment?
Hello, doctor. Am I audible? Am I audible to you all?
Hello, can you hear me, Madam Palvisha?
Yeah, yeah. Yes, yes, we can hear you.
I
Okay,
think
so
my connection got dropped. Sorry.
yeah, yeah. Okay, so the availability of Q banks is for like 3 months for the crash course. But if you need extension, then you will have to pay a little more, and then you'll get extension for like 6 months.
Okay.
Dr.
Can you
Taha,
hear me?
continue.
Can you
Yes,
hear?
yes,
Fine.
yes.
Okay, fine. So we'll start with our main topic of the day, Cushing syndrome. So before going forward with Cushing syndrome, I'll briefly talk about a hormone which is called cortisol. Since Cushing syndrome is basically uh, a condition that is caused by prolonged exposure to high levels of cortisol, we need to know what is cortisol and what are the functions of cortisol. So cortisol, it's it's a mineralocorticoid. It is it's the hormone that is released from adrenal glands, more specifically adrenal cortex. So, if you guys have studied anatomy and you know that adrenal gland is divided into two parts: adrenal cortex and adrenal medulla. Cortex it's the outer part, and medulla is the inner part. Uh, Cortex is further divided into three layers: zona glomerulata, zona fasciculata, and zona reticularis. And each layer is involved in creating a specific hormone. Uh, we have heard the mnemonic uh, salt, sugar, sex, GFR. So salt, it's a mineralocorticoid, which is aldosterone, is released from the top layer, uh, and the glucocorticoid, which is cortisol, it's released from zona fasciculata. So we will just be talking about cortisol today. So before going forward with Cushing syndrome, we will briefly talk about the functions of cortisol. So cortisol is a very important hormone. It's involved in uh, stress. It's called a stress hormone because it is usually released in stress. Uh, its functions are if you know the functions of insulin, you can easily tell the functions of cortisol because cortisol opposes insulin in every way. So first, what it does, it increases the level of glucose. It promotes gluconeogenesis. it promotes lipolysis, it promotes the formation of free fatty acids, and it is a catabolic uh, hormone, whereas insulin is an anabolic hormone. Cortisol is a catabolic hormone. Catabolic hormone means that it loves to break things, and anabolic hormone means that it loves to create things. So anabolism making things, catabolism breaking things. So cortisol is a catabolic hormone. It breaks things. So its main functions are it is your appetite. It raises your blood pressure, and the way it raises your blood pressure is that it has a permissive action on the alpha receptors, and by that it raises your blood pressure. It opposes insulin. That's why it causes insulin resistance, and and that is the main reason cortisol is involved in adrenergic diabetes. We'll talk about that later. So, cortisol, it causes insulin resistance. It also decreases the function of fibroblasts. That's why there's delayed healing when there's excess of cortisol, and you see stretch marks, blue stria, and all the other skin issues with cortisol. It also uh, it also decreases your immunity, and how it does that is basically it opposes the functions of lymphocytes, uh, uh, and it also promotes bone resorption. It promotes basically what you have heard about, that high levels of steroids damages bone. So the reason behind is that cortisol acts on osteoclast and upregulates the osteoclast. And osteoclast, in return, breaks the bone. So it damages the bone. It damages your immune system. It damages your skin. It causes raised blood sugar levels. It raises your blood sugar. And another very important function of cortisol is that uh, I told you that it's a catabolic hormone and it loves to break things. So it breaks protein, and by doing so, it damages your muscles. So it also causes muscle loss and musculopathies. Insulin and cortisol have opposite function. Yes, cortisol is exactly opposite to insulin. So now we have some idea of what cortisol does. One more thing. So before going to this topic, we will briefly talk about the pathway of cortisol, how cortisol releases. So first we have CRH hormone, corticotrophin releasing hormone. It is released from hypothalamus. It goes to the pituitary gland and causes the release of ACTH, adrenocorticotropic hormone, ACTH, adrenocortical releasing hormone. And that ACTH acts on the adrenal gland, and it causes the release of cortisol. And it's very important to know that this pathway, which I've just described, CRH, ACTH, and cortisol, it does not include aldosterone. That is completely different, and that is activated by renin. It is not activated by ACTH or CRH. So that's the pathway. Now, coming to Cushing syndrome, like I said, it's a condition caused by prolonged exposure to high levels of cortisol. And uh, what are the common causes? The most common the most common cause in general is the use of the steroids, exogenous or iatrogenic, uh, and it's most commonly seen in individuals who are uh, uh, suffering from some autoimmune disorders like SLE, rheumatoid arthritis, or any other uh, autoimmune abnormality for that matter. So the most common in general is the steroid use or iatrogenic administration of cortisol. Uh, And the endogenous causes are Cushing disease, which is basically ACTH secreting pituitary adenoma, or it could be an ectopic ACTH secretion, usually seen in small cell lung cancer, and adrenal adenoma, uh, in which there is autonomous cortisol production without the stimulation of ACTH. So the way we classify Cushing syndrome is basically on two things. First, you can either say that exogenous cause or endogenous cause, or you can do it you can do it by assessing the ACTH hormone. So in exogenous is very simple. You're basically giving steroids from outside, and what that does is that steroids uh, causes negative feedback inhibition of ACTH because steroids are high. What they do is that they tell pituitary that stop. We do not need ACTH. Stop producing ACTH. So when that happens, there is no stimulation of adrenal glands. So what they do is that they atrophy. If you're using exogenous steroids, you will see that the adrenals have atrophied because there is no stimulation. Uh, uh, I believe that you all know what a negative feedback is. If you don't, I can explain. So moving forward, Madam Pavisha, can you give the
Dr.
access to?
Taha, should I change the slide?
Yes, I think
All right,
I
all
should.
right, all right, all right.
Fine. So basically, what we need to understand is that uh, endogenous cortisol production happens in two ways. Either it's from excessive ACTH, or either it's from ACTH independent. Either it's ACTH dependent, or either it's ACTH independent. ACTH dependent is almost always Cushing disease. So we class if there is a pituitary adenoma, it's called Cushing disease. Anything else is Cushing syndrome, right? Cushing disease is Cushing syndrome caused by a pituitary adenoma. Okay, and all other diseases classify as Cushing syndrome, but we just in case of pituitary adenoma, it's called Cushing disease. With that one thing in mind, we'll move forward. So there's a there's a mnemonic called Cushing's. You can see that in first aid, it basically summarizes all the uh, side effects of Cushing syndrome, all the symptoms of Cushing syndrome. So C stands for central obesity. You all know that in Cushing's there is central obesity, weight gain, especially around abdomen and face, moon face people, and buffalo hump. You've seen all that. We have been reading about that for ages. There's stria, purple reddish stretch marks, especially on abdomen, thighs. There's hypertension. One thing, I'll briefly go through one thing. So there are two hormones called cortisol and aldosterone. Cortisol is mineralocorticoid. Aldosterone is, uh, cortisol is glucocorticoid. Aldosterone is mineralocorticoid. Usually, cortisol does not act on aldosterone receptors because uh, there is a enzyme called wait, written down 11 beta hyd 11 uh, 11 beta hydroxy dehydrogenase. It converts cortisol into cortisone. So the aldosterone receptors express that enzyme, and what it does is that it converts cortisol into cortisone. And when that happens, cortisol cannot function and cannot activate any receptors. But if the cortisol is extremely high, that enzyme cannot inactivate so much cortisol. So what happens is that cortisol starts to act on aldosterone receptor. So in addition to glucocorticoid activity, it acts like a mineralocorticoid. And we all know the functions of aldosterone is that it absorbs sodium and release potassium. So, and if you absorb so much sodium, you'll retain water, and because of that, your BP will shoot because you're retaining so much water in your body. So that's one way cortisol causes hypertension, and the other one we talked about that it upregulates the alpha receptors, and uh, because of that, your BP raises. It increases your susceptibility to a lot of infections because we said that it decreases your immunity. And how it does your decreases your immunity is that it promotes it promotes apoptosis of the lymphocytes. It promotes apoptosis of neutrophils, and it also promotes apoptosis of your eosinophils. So in USMLE you will see eosinopenia, decreased number of eosinophils. It's a very high yield MCQ. It showed up in my exam. Uh, it I came across a stem of Cushing syndrome, and it was very obvious that this was Cushing. And in the end, they just said, "What will I see in the blood picture?" So they wanted to ask me about eosinopenia. So decreased level of eosinophils is a very important aspect of Cushing syndrome. And another very important thing is that in Cushing syndrome, you see that it promotes apoptosis in neutrophils, but the number of neutrophils are raised in your blood picture. It causes neutrophilia because it inhibits the adhesion of neutrophils and lymphocyte WBCs. So instead of chemotaxis and instead of going to the target site, they stay in the blood and causes a raised level of neutrophils. But actually, they are not raised. They're just uh, there because the adhesion is malfunctioned. They also cause neuropsychiatric symptoms, which include mood swing, depression, anxiety, and cognitive difficulties. And we have discussed that they cause skin changes, which include thin skin, bruising, delayed wound healing. All these symptoms are because of decreased fibroblast activity. They basically cortisol have a very uh, bad effect on or fibroblasts. It decreases the function of fibroblasts. Fibroblasts do not work well under high levels of cortisol. So what happens is that we get thin skin, we get bruised easily, we get delayed wound healing, and it also causes osteoporosis and muscle weakness. I've explained that osteoporosis is caused by the upregulation of osteoclast. Osteoclasts break bone, and when that happens, we get osteoporosis, and we also get musculopathies. It's called steroid-induced myopathy. Uh, it's very common in Cushing's because Cushing's cortisol is a catabolic hormone. It breaks things. It breaks proteins. It breaks proteins into amino acids, and muscles are basically proteins. So yeah. Can we move forward, please? So so we know that if someone is having symptoms of Cushing syndrome, how will we go forward? How will we diagnose that patient? So first thing you need to do is check the levels of cortisol. See if the cortisol levels are actually high or not. So we have three tests that we can do to check the levels of cortisol. First is 24-hour urinary pre-cortisol. First, we can check the 24-hour urine free cortisol. Then we can check late night salivary cortisol. And uh, the third one, it's actually tricky, and a lot of people mess this up, is that we can also do low dose dexamethasone suppression test. Low dose dexamethasone suppression test, not the high dose dexamethasone suppression test. So before going to high dose dexa suppression, before going to imaging, first we need to see that do we actually have raised levels of cortisol in our blood or not, and how we do that is by these three tests. So 24 hours urinary free cortisol, late night salivary cortisol, and the third one is low dose dexamethasone suppression test. So we have done any of we could do any of them to check what are the levels of cortisol. Let's suppose that we have high levels of cortisol. We did one of them, and we the test showed high levels of cortisol. What next? So the next thing you're gonna do is you're gonna see the ACTH. So like I said, if we all know the normal feedback mechanisms, we have read about them. I don't know, for ages we are reading about them since ages. So if something is high, it goes back, tells the main brain that stop producing uh, the enzyme, stop producing, or let's suppose in the case of Cushing syndrome, cortisol is high. Cortisol will tell the hypothalamus that stop. We have enough cortisol. Uh, Lower the production of CRS. So CRS will go down. Similarly, cortisol will go to the pituitary and tell that enough. We do not need cortisol. Lower the production of ACTH. ACTH will go down. This is the normal cycle. This is normal homeostasis. So if the ACTH is high, so if the ACTH is high and cortisol is high, it means that something is wrong. This is not normal physiology, because if the cortisol is high, ACTH should be low. This is the normal feedback mechanism, and this is the normal homeostasis. So first thing we're going to do is that we're going to see ACTH. If the ACTH is suppressed, that is, if the ACTH is on the lower side, it's ACTH independent Cushing syndrome. What is that? It could be exogenous use of steroids, or it could be uh, an adrenal adenoma, or it could be bilateral adrenal hyperplasia. So if the ACTH is suppressed, your differentials are very limited, and it's very easy to diagnose. Uh, if the ACTH is low, then you either have an adrenal adenoma, you have bilateral adrenal hyperplasia, and the most common cause, which we discussed previously, was exogenous use of steroids. This is the most common use of cause of Cushing syndrome in general. So if the ACTH is suppressed, we have these three things to blame, which is adrenal tumor, adenoma, adrenal hyperplasia, or exogenous use of cortisol. And how will you differentiate between these two? Is that you will do CT of your adrenals to confirm if there is a mass or if there is hyperplasia. Remember, in case of exogenous use of steroids, your adrenals will atrophy because ACTH has gone down very low, and there is no stimulation of your adrenal gland. So what that will do is that will cause the atrophy of your adrenal glands. Another important thing, if there is an adrenal adenoma, what will happen then? Adrenal adenoma, let's suppose there's an adrenal adenoma in one adrenal gland. It will cause the secretion of cortisol. That cortisol will go up and cause the feedback inhibition of ACTH and CRS. So there is no uh, ACTH and or there is no CRS, so there is no stimulation of the other healthy adrenal gland. This gland, let's suppose this is one adrenal gland. This is a second adrenal gland. This gland has an adrenal adenoma or any other tumor, but this is the fine gland. This one is producing cortisol, uh, with excess cortisol, and that excess cortisol is going up, causes the feedback and inhibition of ACTH. Now ACTH has gone down very low. There is no ACTH to stimulate this healthy gland. So what will happen is that this gland will shrink, and this gland will continue producing your high levels of cortisol. So image what the imaging will tell is that we have atrophy of one gland and hypertrophy or mass in another gland. So this is a picture of adrenal adenoma or adrenal tumor. And in case of exogenous use of steroids, we basically will have bilateral atrophy of our adrenal gland, because now there is no ACTH, there is no stimulation of adrenal glands. So we the both adrenals are atrophied because there is no stimulation. So yeah, if the ACTH is low suppressed, our job is very easy. We just need to do imaging to confirm what's next. But if the ACTH is elevated, so what then? So if the ACTH is elevated, so that means that it's an ACTH dependent Cushing syndrome. Now what will you do is that forget this CRS stimulation test. It does not show up and it confuses a lot of people. First, we're going to talk about how high dose dexamethasone suppression test. So, like we said, that the normal physiology is that hypothalamus releases CRS that goes to the pituitary and causes the release of ACTS, and ACTS goes to the adrenal gland and causes the release of cortisol. So this is the normal physiology. Now, we have discussed that there are two causes of endogenous ACTH production. It could be either by pituitary adenoma, which is Cushing disease, or it could be an ectopic secretion of ACTH, or a paraneoplastic condition, mostly seen in small cell lung carcinoma. How will you differentiate between these two? Because ACTH is high in both of them. So if that's the case, you will do high dose dexamethasone suppression test. What high dose dexamethasone suppression? Not this uh, medium dose or low dose dexamethasone, high dose dexamethasone suppression test. In high dose dexamethasone suppression test, what will happen is that if you give really high levels of dexamethasone, it will cause the negative feedback inhibition of uh, your pituitary adenoma secreting ACTH. So, in case of Cushing disease, which is caused by a pituitary gland tumor, high dose dexamethasone suppression will cause suppression of your ACTH and cortisol production. But in case of in case of ectopic ACTH production. Ectopic ACTH production means basically production of ACTH outside the pituitary gland. It could be from anywhere else in the body, not necessarily lungs because of small lung carcinoma, but any place outside your pituitary is ectopic secretion of ACTH. So if there is no suppression after high dose dexamethasone suppression test, it is probably because of some sort of cancer, not in the pituitary gland, somewhere else in the body, right? So moving forward, so this is just the brief summary of what I've discussed in the previous algorithm. First step is to measure levels of cortisol, and how we do is that we do 24-hour urine cortisol, uh, we do late night salivary cortisol, and we do low dose dexamethasone suppression test. And then we have the confirmatory tests, which are used to distinguish between ACTH dependent and ACH. We used to differentiate between ectopic and non-ectopic condition. Uh, Low dose, if no suppression, suggests Cushing syndrome. High dose help distinguish between this. We have discussed this. This is just to uh, briefly revising the previous uh, algorithm. You can move forward. So the important differentials. What is the Cushing disease? Cushing disease is basically high. In Cushing disease, your pituitary is secreting excess ACTH, and that excess ACTH is causing hyperstimulation of adrenal gland, causing high levels of cortisol, uh, leading to Cushing syndrome, right? So in Cushing disease, your ACTH is high, your cortisol is high, but if you give very high levels of dexamethasone, high dose dexamethasone test, it causes the suppression of your pituitary ACTH production and cortisol production. In ectopic ACTH secretion, your ACTH levels are high, your cortisol levels are high, but high dose dexamethasone suppression test does not cause the suppression of cortisol and ACTH. And then in adrenal adenoma uh, uh, or adrenal tumor of adrenal gland, your ACTH is low because uh, ACTH, the adrenals are producing cortisol uh, independent of ACTH. So in adrenal adenoma, you have high levels of cortisol, but low levels of ACTH because pituitary and hypothalamus is fine. So and it also does not suppress with high dose dexamethasone suppression test. Move forward, please. Uh, Before going to the questions, there are a few details that I would like to share with you guys. First, there is another way of telling that whether it's an adrenal cause or it's a peripheral cause or central cause in case of Cushing syndrome. So, if you see hyperpigmentation of your body, it means that there is a central issue. Your ACTH levels are high. So, and why I'm saying is that because there's a hormone called melanocytes stimulating hormone. Uh, it is very similar to the adrenal corticotropic stimulating hormone ACTH. Uh, Both of these hormones basically originate from a compound which is called propiomelanocortin POMC. So they share similar structure. So if the ACTH is very high, what it does that it causes uh, it stimulates the melanocytes and that cause pigmentation. So if you see pigmentation in the body, it's almost always a central cause, either from pituitary adenoma or from ectopic secretion of ACTH. So if you are going through a question and that says that patient has hyperpigmentation of the skin, you can rule out the exogenous ACTH, exogenous use of steroids. You can rule out adrenal adenoma. You can rule out uh, adrenal hyperplasia or any other peripheral cause involving the adrenal glands. So that's one hack to uh, go about these questions. And there is another condition mentioned in the first aid. Let me see. It's called Nelson syndrome. So Nelson syndrome is basically a condition that if you have a pituitary adenoma and you somehow mess up and you do not diagnose it correctly, and what you do is that in order to treat the patient, you take out his or her adrenal glands. So if now you have taken out the adrenal glands, there is no production of cortisol. So there is no feedback inhibition of your pituitary gland. So now it will grow exponentially because there is no feedback inhibition of your pituitary gland. So what will it do is that it will cause rapid expansion of the pituitary tumor, and it will cause mass effects uh, in your brain, which is bitemporal hemianopia, headache, and all those sort of things. So it's just one thing that you need to know. It's called Nelson syndrome, and it is caused by removal of your adrenal glands that uh, stops the feedback inhibition of pituitary, causing it to enlarge and causing mass effects in our body. So yeah. Uh, Go backward, please. Sorry. Okay, so we'll do this question. I'll read the question out loud. You guys can read it too, and you can try to answer that in the comment. So, a 40-year-old woman presents with weight gain and fatigue. On examination, she has moon phase and proximal muscle weakness. Lab results shows an elevated 24-hour urinary cortisol level. The dexamethasone suppression test is performed and shows no suppression of cortisol production, even with high dexamethasone suppression test. Plasma ACTH levels are low. So, which of the following is the most likely diagnosis? You guys can answer, and then I can show how I will approach this question. So, this is like I said, if you know the levels of ACTH, you you are almost halfway there. So ACTH levels are low. It means that the cause is not central. It is ACTH independent. That meaning that it involves, someone said, C. So Kashif is saying it's called by ectopic ACTH syndrome. It uh, it says that plasma ACTH levels are low. In ectopic ACTH syndrome, ACTH levels would be very high, not low. So, like I said, if the ACTH levels are low and cortisol levels are high, it means that it is ACTH independent uh, Cushing syndrome. And ACTH independent Cushing syndrome is caused by three things, which were exogenous use of glucocorticoids, right? Adrenal adenoma, and any other sort of adrenal tumor, right? So the answer to this question is adrenal adenoma, because ACTH levels are low and they have not mentioned any use of exogenous steroids. She does not have any autoimmune disorder, so we cannot assume that she is taking steroids. One thing, never assume anything that she or he's taking this, or she's taking this, unless you have been given a hint about something. Never assume something in USMLE. Never. Rule number one: never assume anything unless you have been given a clue in this stem. This stem, there is no clue that this person or this lady is taking steroids. Uh, she does not have an autoimmune disorder. She does not have an addiction. So we will not assume that she's taking exogenous glucocorticoid. So the correct answer to this is B. Move forward. So another question. Uh, a 42-year-old woman with a history of rheumatoid arthritis presents with a 3-month history of weight gain, mood swing, easy bruising. She also reports fatigue, muscle weakness. On examination, she has purple striae on her abdomen, proximal muscle wasting. Lab, lab studies reveals low ACTH level again. ACTH levels are low. It means there is feedback inhibition of pituitary and hypothalamus. So it is Usually you can tell that the person has Cushing syndrome because the symptoms are very obvious. Now they're most likely they're going to ask you about what's the cause of that. So you need to find that out. So ACH levels are low. It means that it's not a central issue. Hypothalamus and pituitary are fine. So mark elevated 24 or urinary cortisol. We know that cortisol levels are high. That's why the patient is having cushingoid features in her body. Uh, then it says that there's decreased plasma cortisol levels in the morning. Okay, fine. Impaired cortical suppression with both low dose and high dose dexamethasone suppression test. Okay, fine. Move forward. No. An adrenal CT scan shows bilateral adrenal atrophy. What is the most likely underlying pathophysiological mechanism of this patient? It's very easy. Do you guys want to answer? Uh, let's see. What's the answer of this question? You don't even need to read the whole stem. This line is enough. Bilateral adrenal atrophy. So if the if the adrenal glands have atrophied, it means that there is bilateral atrophy of adrenal gland. So this suggests that either she's taking an exogenous steroids, right? Because the ACTH levels are very low, and she has Cushing's features. So, and I like uh, uh, when I was discussing low levels or ACTH independent conditions, I gave you guys a idea that what our adrenals would look like in case of exogenous use, in case of bilateral adrenal hyperplasia, in case of adrenal adenoma or adrenal tumor. So yeah, she mentioned that she has rheumatoid arthritis. I said that never assume anything until unless you have been given a clue. So this patient has an autoimmune disorder, meaning that she most likely takes glucocorticoids, and for that reason, her ACTH is suppressed. And because her ACTH is suppressed, there is no stimulation of adrenal glands. And if there is no stimulation, your glands will atrophy, and that will cause the atrophy of your glands. And the answer to this question is exogenous corticosteroid use leading to adrenal atrophy. So that's that. So, like I said, uh, if you Cushing symptoms are very easy to pick. You will know that this person is suffering from Cushing syndrome. Next thing you need to do is that you need to find the source of that disease, whether it's central, whether it's peripheral, whether it's exogenous, whether it's endogenous. How will you do that? First, you will check you will confirm the levels of cortisol. You know that this person has high levels of cortisol, but you will still confirm that he or she has high levels of cortisol. What will you do is that you will do three tests. 24 urinary cortisol. You will do you will do late night salivary cortisol, and you will do low dose dexamethasone separation test. Now, after doing these tests, you know that this patient has high levels of uh, cortisol. Next thing you are gonna do is you're gonna see the ACTH levels. ACTH levels, they will either be suppressed or they will be increased. If they're suppressed, your job is very easy. You know that it's not his or her hypothalamus, it's not his or her pituitary. So it's something related to her adrenal glands. So you will just uh, do an imaging of the adrenal glands and find the cause of it. But if the ACTH is high, it means that it's the central cause. It could be either an ACTH secreting pituitary adenoma, which is called the Cushing disease, and or it could be your ectopic secretion of ACTH, which is most likely seen in lung cancer, but it can be seen with any other cancer as well, with paraneoplastic presentation. So yeah, that's it. Uh, if you guys have any questions about this topic, you can ask. I did not create a slide for the treatment of Cushing syndrome because treatment is very straightforward. If we find a tumor, we resect it. If we don't find a tumor, what we do is that we can do a trial of. We can use some drugs. One is uh, ketoconazole. That often shows up, but uh, medical management is often does not really help. All we do is that we resect the tumor or we resect the adrenal glands. Yeah. So if you guys have any questions, you can ask. That's it. Madam Palvasha, do you want to talk about the course? Anything that I've missed?
Yes, Dr. Saha, I'd like to speak to them.
Sure. Take over.
You can answer the questions first if there are any questions.
Yeah, sure.
I guess there are no questions, so we should just wind it up. But before leaving, I would like to thank you all. Heartfelt thank you to all the USMLE aspirants who attended our webinar today. Your dedication to your medical journey is truly inspiring. A special appreciation to our mentor, Dr. Taha, for taking the time to deliver such an insightful session on a high yield topic. As a token of our appreciation, we are thrilled to offer an exclusive flat 50% off on both our courses, the crash course and the regular course. So, and it's also available for the webinar attendees. And this is a limited time offer, so just don't miss it out. To avail this discount, kindly reach out to our team on the shared numbers in the chat. Once again, thank you all. Wish you all the best. Nimra, we are done here.